Hello everyone, this is Dr. Amber Can. Today we're going to talk about the medication management of hypertension. Hypertension is something you will treat every day in your practice, and it's something that is often layered with many other disease states, and it certainly complicates lots of other disease states. So yes, hypertension is relevant to no matter what type of specialty you go into. There are lots of published guidelines on how to treat hypertension. Two of the main ones that are accepted by generalists are the JACC, or the Journal of American College of Cardiology, and the JNC8. In your lecture notes, you have the links to both of these. So let's get into a brief review of the pathophys of hypertension. Hypertension, of course, is a chronic and life-threatening condition that increases the risk of many other diseases and complicates many other diseases. We see patients who have increased risk of coronary heart disease, heart failure, stroke, kidney failure, all because of untreated or poorly treated hypertension. When we measure blood pressure, of course, we measure two different readings. The systolic is the heart at work, and the diastolic is the heart at rest. The JNC8 diagnosis and staging guidelines present this framework. It is generally accepted that normal blood pressure will fall below 120 for systolic and below 80 for the diastolic. The most recent iteration of the JNC8 guidelines is added this pre-hypertension status. Before, it just outlined these stage 1 and stage 2 hypertension categories. But now we have this pre-hypertension category that can help us even be more vigilant with our patients. So a patient who has continued or an average blood pressure readings that are ranging between 120 to 139 for systolic and between 80 and 89 for the diastolic can be considered in the pre-hypertension stage. And of course, going forward, stage 1 hypertension and stage 2 hypertension are outlined here as well. The stage of the blood pressure category is not as important when we are talking about actually selecting medication therapy for a patient. When we select medications, we're thinking more about patient characteristics. The first thing that we do when we decide to start a patient on hypertension medication is that we set a goal for the patient's blood pressure. And this is what the JNC8 and other guidelines have recommended. For the general population over 60 years old, this is the only one that really differs. The goal blood pressure is below 150 over 90. So we can increase the systolic just a bit by 10 points here to 150 in patients who are over 60. And the reason is patients over 60 are more likely to have adverse effects from hypertension medications. They're more likely to be at fall risk, and especially when we add on blood pressure medications. So we can give them a little more leeway in that systolic blood pressure so that we don't push them too far down and cause them to have too many adverse effects. For every other type of patient, we set a goal below 140 over 90. Now, that is not to say that we're shooting for 140 over 90. We're saying below, of course, 140 over 90. So for any patient under the age of 60, we want their blood pressure to be consistently below 140 over 90. For patients of any age with diabetes, we want them to be below 140 over 90. And any patient of any age with chronic kidney disease should be below that number as well. You can see some initial treatment drug options listed here. We're going to go through those in detail in the following slides. No care plan for a hypertensive patient would be complete without first addressing the lifestyle modifications. Any patient that is first diagnosed with hypertension or even pre-hypertension should be introduced to lifestyle modifications like diet and exercise changes that would need to take place. Ideally, the patient could meet with a dietitian. They could meet with an exercise therapist to increase their amount of movement per day, help them perhaps lose weight, because generally people with hypertension might benefit from losing a bit of weight. So these lifestyle modifications are vastly important. In fact, some people with pre-hypertension may be able to get themselves back down to a normal blood pressure just with lifestyle modifications alone. Of course, for many patients, the lifestyle modifications will not be the only thing that will get them down to goal. So we must initiate medications. But it must be clear to the patient that just because we start medications does not mean that lifestyle modifications can go back to what they were. Those must be continued as well. They are certainly part of the care plan, just like medications are. So we set a goal for the patient. We initiate medication based on patient-specific factors. Published guidelines also often include a nice flow chart for you to have on hand when you're treating a patient or initiating medication therapy especially. So here's an example of one of the interventions that we would take and how they fit into a particular patient. So here we start, and we have a patient who has been diagnosed with hypertension. They implement those lifestyle interventions, and then we set a goal for them if those interventions do not lower their blood pressure on their own. So at this point, we put them into a category: either they have diabetes or chronic kidney disease, or they do not. They would be in the general population. If they're in the general population with no diabetes or CKD, then we further differentiate them by age, either under 60 or over 60. If they are not in the general population, if we are in the diabetes or CKD part of this flow chart, then age does not matter. We are more focused on what the disease state is. So either diabetes is present or CKD is present. Once we set a goal for the patient's blood pressure after initiation of medications, we can further differentiate before we select a medication into the race of the patient. If the patient is non-Black or non-African American, there are some recommendations on initiating a medication. And African American patients do have slightly different recommendations for which medications to select. For patients over here in the CKD and diabetes realm, the race is not as important. The recommendations tend to be the same. Then, of course, once medication is selected, we reassess. Are the goals being reached that we set for the patient? If no, then we reassess. We make sure the patient is adherent with their medication and their lifestyle modifications, and then we may consider adding another medication or changing our therapy in some way. So what does happen when the patient isn't at goal? The patient seems to be adherent with their diet and exercise. They seem to be taking their medication properly. So what is to be done? The first strategy I would recommend is after starting the first dose, you want to titrate to the maximum dose for that first drug before starting a second drug. This could be considered your first plan. You start on, for instance, a thiazide diuretic. Before even considering a second drug, you want to make sure that you're really maxing out that first drug and getting the most potential out of it. A second strategy that could also be considered is starting with the first drug, and then before maxing out on that first drug, adding the second drug. It could be argued that by maxing out doses of that first drug, you're just putting the patient more at risk for adverse effects without getting much exchange in terms of efficacy of the drug. And I do tend to agree with that somewhat, and it depends on the drug, of course, but you could make an argument for some drugs that by maxing out, you're not quite getting the most benefit out of the drug. adding a second drug before you max out the first drug might be beneficial to the patient. And then when you have the two drugs on board simultaneously, you titrate the doses to find where the patient needs to be for their goal blood pressure. A third strategy is not something that you use for every patient, really only those patients in that second category of hypertension stage 2, when systolic is consistently over 160 or diastolic is consistently over 100, you really just begin with 2 medications. They've really passed the point of starting with 1 medication at that point, so they really do need to start with 2 drugs. Now that could be a combo product that it's a 1 medication, 1 pill or 1 capsule tablet that has 2 drugs in it. That is a possibility. Or if you need to fine tune it a little bit more, you could start with 2 separate medications that you can change the doses independently of each other. But again, strategy 3 is really conserved for those patients with stage 2 hypertension or those that are running incredibly high on the blood pressure range. Oftentimes we select a blood pressure medication based on other disease states that the patient has. This is a quick summary of the drug classes that we're going to discuss and the other disease states that have an indication for those drug classes. We'll start our discussion on treating hypertension with medications with the diuretics because the guidelines start with diuretics as well. For virtually every patient, diuretics are indicated as first-line therapy. Even if the patient has to start on 2 medications, the diuretic is usually a part of that mix. The first type of diuretic that is considered are the thiazide diuretics, and that includes hydrochlorothiazide and metolazone. These are considered fairly mild diuretics, but are indicated to be a starting point for most patients. The next type of diuretic are the loop diuretics. Those include bumetanide, torsemide, and furosemide. Loop diuretics tend to have a bit of a stronger effect than the thiazide diuretics, and we'll see why that is in just a moment. And they tend to be used if a bit of a more bang for your buck needs to happen to lower blood pressure with a diuretic. The third type of diuretic is the potassium-sparing diuretic. This category includes triamterene, eplerenone, and spironolactone. This category works slightly differently than the other 2 categories, and we'll look at those in particular in the next slide. Thiazides and loops work very similarly. It's just the location in the kidney where they make their action. First, let's talk about thiazides. So thiazides work on sodium and chloride reabsorption in the distal tubules in the kidneys. And when those ions are reabsorbed, water will follow those ions into the distal tubules. That increases urinary excretion of the ions as well as water. More water in the urine means less water content in the blood and therefore lower blood volume and lower blood pressure. I will say that although it's not directly working on potassium ions, potassium also tends to be wasted with the thiazides because the body doesn't do a great job about distinguishing between sodium and potassium since they are both single cations. Loops, on the other hand, also work similarly with sodium and chloride ions, but they have 2 different places that they work, and therefore it could explain why they're a little more powerful in terms of lowering blood pressure through the diuretic action. They work in the distal tubules, similar to thiazides, but they also have action in the ascending loop of Henle. This is where they get their name. The loop diuretics work in the loop of Henle. They also tend to waste potassium. Potassium-sparing diuretics, as you might gather, do not have this wasting effect on potassium, and they work differently than the other 2 diuretics we discussed. They compete with aldosterone. It's a hormone called aldosterone for their receptor sites in the distal tubules. They're working in the same location in the kidneys, but an entirely different type of mechanism. So by competing for aldosterone, those diuretics that are potassium sparing are increasing sodium chloride and water excretion into the urine. Similar function as the loops and diuretics in that way. The water is following the sodium and chloride ions into the distal tubules. However, it is having the effect of the potassium is not following in the same way the sodium would be. So more urine in the kidneys is excreted, less blood volume, lower blood pressure. So that's the difference between the thiazides, the loops, and the potassium-sparing diuretics. The first thing I want to mention about diuretics is that loop diuretics have a boxed warning applied. And that warning says that if loops are taken in high quantities, then a profound loss of volume and electrolyte disturbances can result. That's probably no surprise to someone who knows how the loop diuretics work, as you all now do. So we would hope that patients are taking them as we direct them to, but if a patient is taking more than the dose that is prescribed, or if we are overdoing it with the dose that we're giving them, then we put the patient at risk for electrolyte imbalances. That, of course, could have far-reaching consequences for the patient's cardiovascular system as well as their renal system. All right, so we've talked about the electrolyte imbalances. Even at normal doses, some electrolyte imbalances can occur, so we need to monitor electrolytes for all patients to whom we prescribe diuretics. And of course, in particular, we want to monitor potassium in those patients who are on potassium-sparing diuretics, because those patients are very much at risk for hyperkalemia. Patients with other underlying disease states like hepatic dysfunction, history of kidney stones, diabetes, patients with increased fall risk like the elderly, and a history of gout all need to be monitored ever more closely when we give them diuretics, because we put them more at risk for these diseases or complications of these diseases with diuretics. We can use thiazides and loops in pregnant patients. We typically use thiazides because they are pregnancy category B. In general, loops and triamterene are category C, as well as spironolactone. So typically, if a patient is in need of a diuretic who is also a patient who is pregnant, thiazides are typically the drug of choice. Most common adverse reactions we'll see from diuretics across the board are those electrolyte disturbances and the complications from volume depletion, which includes hypotension. Sometimes as doses creep higher, we can get in the thiazides, we get hyperuricemia, increases in uric acid, and that can lead to gout. Because of spironolactone's action on hormones like aldosterone, it can cause some gynecomastia or breast tissue development in male patients. It's typically something you only have to worry about if doses are high and therapy is prolonged. And if it's something that is of concern, or it is something that does develop, you can switch the patient to another potassium-sparing diuretic like eplerenone. Diuretics have their number of drug interactions, and usually they're things that also affect the way the kidneys function or affect potassium levels. One of the more insidious interactions that people often don't think about are salt substitutes. When we counsel a patient on reducing their salt intake as part of their lifestyle modifications with hypertension, their patients are often told to try some salt substitutes in their diet. Oftentimes, these salt substitutes are potassium chloride based. By adding potassium chloride into the diet, we are affecting potassium levels. And if we are giving them a potassium-sparing diuretic, then we could be pushing the patient into hyperkalemia, and that could be very dangerous from a cardiovascular system standpoint. The diuretics work with the mechanisms of the kidney's natural function. And so if we have patients whose kidney function is diminished, most of the diuretics are not a good choice. So patients who have kidney dysfunction or creatinine clearance below 30 mils per minute, typically we stay away from diuretics. However, one particular diuretic, it is a thiazide diuretic called metolazone. It is effective even when creatinine clearance drops to the 20 mils per minute range. Loops could also be a choice in some patients with renal disease because they do have that dual place of mechanism, the loop of Henle and the distal tubules. All right, now that we've talked about diuretics, let's move on to the angiotensin agents. The renin-angiotensin system is complex, it is multi-system, and it has multiple entry points where drugs can make an intervention to affect blood pressure. Let's first talk about ACE inhibitors. ACE inhibitors, of course, ACE stands for angiotensin converting enzyme. It blocks the action of that enzyme and therefore blocks conversion of angiotensin 1 into angiotensin 2. It also happens to inhibit the breakdown of bradykinin. By doing this action of the conversion, blocking the conversion of AT1 to AT2, it subsequently lowers blood pressure, it improves oxygenation to the myocardium, the muscle tissue of the heart, and it also offers some renal protection, especially in diabetic patients. Here's a detail of the diagram I showed you of the renin-angiotensin system from before. Angiotensin 1 is converted into angiotensin 2, and ACE inhibitors find their entry point here to inhibit this process from happening. There are a number of ACE inhibitors on the market now. Most of them are available in a generic form. They differ very little in the efficacy and safety profile. Most of them are once daily dosing, with the exception of captopril. And selection of one over the other may come down to patient experience with one or insurance coverage, affordability for the patient. One of the main things you should remember about ACE inhibitors is there is an absolute contraindication against using them during pregnancy or for patients who are considering becoming pregnant. ACE inhibitors are pregnancy category D, and it has been shown in human trials that exposure to an ACE inhibitor during the first trimester has been associated with increased risk of fetal malformation. It's so important here to ask patients about their plans on conceiving, especially if they are of childbearing age, because in that first trimester, those first few weeks, the patient may not even know that they are pregnant. And we want to minimize as much as possible the exposure of an ACE inhibitor during that first trimester. One of the more common adverse effects of ACE inhibitors is a dry cough. This dry cough seems to be related to ACE inhibitors' action on bradykinin. That's why I mentioned it before. And by inhibiting the breakdown of bradykinin, it seems to be one of those factors that cause this dry cough. Unfortunately, if a patient develops a dry cough, it may mean that the patient needs to stop an ACE inhibitor altogether. It will probably happen with any other ACE inhibitor. Backing off the dose of the current ACE inhibitor could relieve that dry cough, but it also may not help the patient achieve a blood pressure goal. So typically if the patient experiences a dry cough, we move on to another class of drugs that we will talk about in just a moment. The other serious adverse reaction that we must be aware of for ACE inhibitors is angioedema. I'm going to go more into detail about that in just a moment. To monitor patients on ACE inhibitors, we of course look at their renal function by way of serum creatinine. We want to monitor their potassium because one of the other adverse drug reactions is we can increase potassium levels with ACE inhibitors. And if we're not monitoring the potassium, we could be pushing them into hyperkalemia. And of course, we want to monitor blood pressure to make sure that the medication is working. Angioedema is this swelling of the deep layers of the skin and other tissues that can be caused by ACE inhibitors. It can be caused by other medications as well, but ACE inhibitors are very well known for causing this. Here are some examples in these photos of what that may look like. And you can see if it's the tissues of the respiratory system or the face, the swelling can quickly obstruct the airways. This could be life-threatening. In more mild forms, it could cause a shortness of breath or dizziness, but this is something that would need to be treated in an emergency situation. If the patient does have a history of angioedema, then ACE inhibitors should be avoided altogether in those patients. ACE inhibitors are well known for increasing potassium, and so potassium supplements, of course, and salt substitutes, which we now know often are potassium chloride, should be used sparingly, if at all, in patients who are taking an ACE inhibitor. Maybe even more common is the interaction between NSAIDs and ACE inhibitors. They both may reduce the other's effectiveness. So NSAIDs could lower the blood pressure lowering effects of ACE inhibitors, and vice versa. ACE inhibitors could attenuate the action of NSAIDs. I'm more concerned about the attenuation of blood pressure lowering effects of ACE inhibitors with NSAIDs, but the combination of these two actually can be very damaging to the kidneys because of their action and how they work on fluid through the kidneys. So I would recommend low doses if NSAIDs must be used when an ACE inhibitor is on board, and really, if possible, avoid NSAIDs altogether while a patient is taking an ACE inhibitor. Now we move on to that first cousin of ACE inhibitors called the angiotensin II receptor blockers, or more friendly, the ARBs. They are also drugs that interact with this angiotensin-renin system, and they are more specific in that they block the AT1 receptor. In doing so, they inhibit vasoconstriction, but they don't have that effect on bradykinin. If you recall, bradykinin seems to be that mediator that causes the adverse effect of dry cough in the ACE inhibitors. So it's nice that if we have someone who is on an ACE inhibitor that has the dry cough, we can probably switch them to an ARB and have less chance of them getting a cough, and they would still have all the benefits of what they were getting from an ACE inhibitor. ARBs seem to have less risk of angioedema too. However, I will say that if you do have someone who has a known history of angioedema, especially with ACE inhibitors, ARBs may not be the best choice. They can be used. The risk is very low. Angioedema is very rare anyway, but just to be on the safe side, I probably would avoid an ARB in someone who has had angioedema related to an ACE inhibitor. So visually, here we are at the ARBs. The ARBs are blocking the action of the AT1 receptor. And this receptor, if you recall from the larger diagram, is one that mediates vasoconstriction and also sodium and fluid retention. There aren't as many ARBs as there are ACE inhibitors, but there are quite a few. Most of them are available in generic form, and among them, they all have pretty much the same safety profile and the same efficacy. They are all once-a-day dosing, and so selection of a item within this group probably will come down to perhaps patient experience with one of them in the past, or the ability for a patient's insurance or their third-party payer or their out-of-pocket pay to afford one of the selected items. Just like ACE inhibitors, ARBs are also category D in pregnancy. So we should avoid ARBs in patients who are pregnant or are thinking about conceiving. We want to avoid at all costs exposure to ARBs in the first trimester because of that risk of fetal abnormalities. This class of drug is tolerated very well, much like the ACEs. You may see patients who are a little dizzy at first, may experience some orthostatic hypotension, especially in the first few weeks, because their body is adjusting to new normal levels of fluid and blood pressure. This is also a class of drug that could cause some hyperkalemia, so we will need to monitor their potassium as we see them back for clinic visits. Another note here on ARBs and ACE inhibitors for that matter, in the short term, as we are monitoring the patient when they first begin an ACE or an ARB, the patient's serum creatinine could actually jump a bit if you were to monitor it in the first few weeks after starting an ACE or an ARB. It's not something that is of concern. It's just an artifact of the ARB or the ACE starting to change the fluid retention and sodium status of the patient. So if you were to check a serum creatinine as part of your regular monitoring of the patient, don't be alarmed that serum creatinine jumps a little bit. Actually, I would just wait and recheck it in a month or so, and you'd probably see serum creatinine has gone back to its baseline level. And now we have come to aliskiren. The brand name of this is Tecturna. If ACEs and ARBs are first cousins, then aliskiren is that weird family member who shows up at the family reunions and nobody is quite sure how they're related. The aliskiren is a renin inhibitor, so I suppose it's related because it's in the renin-angiotensin system. This one is only approved for treating hypertension, and it's marketed only as an add-on therapy to an ACE or an ARB. So really we don't use it alone, and it's only meant to be added on to an ACE or an ARB, presumably if the ACE or an ARB isn't quite getting the patient to blood pressure goal. However, it's not recommended for patients with diabetes or renal impairment because it actually showed in studies that it worsened renal impairment. It caused hypotension, it caused hyperkalemia, and even increased the risk of death and strokes. This drug is only available in brand name form, so it's very expensive. Given its safety profile, its very narrow usage, and its limitations on indication, and the fact that it's very expensive, I just don't see its place in therapy. It's questionable on me that you would ever reach for this drug as opposed to something else when treating most patients for hypertension. This is where aliskiren has its action. It limits the conversion of angiotensinogen to angiotensin 1. So it's working further up the ladder than the ACEs and the ARBs. I just want to reiterate that drugs that interfere with the function of the renin-angiotensin system can be risky in patients who are pregnant and should be avoided if patients are considering conceiving. The risk is at its highest in the first trimester. And oftentimes, early on, patients may not realize that they are pregnant. So if a patient is even considering conceiving and is on an ACE or an ARB, we would want to start the process of switching them over to another medication that is not a category D, something that is either a B or C, something that has a proven safety record in pregnancy. Now let's talk about calcium channel blockers. Calcium channel blockers are a group of drugs that have a wide range of indications, not just for hypertension, but also angina, coronary artery disease, certain arrhythmias, in addition to many off-label uses like migraine prophylaxis and Raynaud syndrome. So calcium channel blockers are something that you're probably going to see in a wide range of patients. Their mechanism of action is that they block the voltage-dependent calcium channels in the vasculature, and therefore they work to relax the smooth muscle. There are two categories of calcium channel blockers: the dihydropyridines and the non-dihydropyridines. You may see dihydropyridine abbreviated DHP. The non-dihydropyridines have a negative inotropic effect, which means that they reduce heart rate and heart contractility. That's going to be important when you're treating someone for conditions like migraine or like angina, who also may be prone to heart failure or who have reduced ejection fraction. We would not want to give something that reduces heart rate or heart contractility to someone who already has the first stages of heart failure. Here is a listing of the DHP agents and the non-DHP agents in the calcium channel blocker category. Really, there are only two non-DHP agents, so that should make it easier to remember: verapamil and diltiazem. Those are the two non-DHP agents, and those therefore are the ones that we would not want to use in people who have heart failure, reduced ejection fraction, or who have bradycardia as a result of something else. The DHP agents are more in number, and they all end in PINE, pine. So amlodipine, felodipine, izropine, nifedipine, nicardipine, and nizlodipine. All the calcium channel blockers are, to some extent, hepatically metabolized, so we need to avoid those in people who have severe liver impairment. From a adverse drug reaction standpoint, of course, they can cause some hypotension if the dose is too high or in the first few weeks of treatment. Another common complaint is heartburn or GERD when a patient is taking calcium channel blockers. Sometimes the dose can be backed off a bit if it doesn't affect blood pressure too much, but usually it's a side effect that either has to be sort of managed, or if it's too problematic, then perhaps another drug class needs to be investigated. And again, for patients who have new or worsening heart failure, we definitely need to avoid those non-DHP agents, verapamil and diltiazem. Now we move on to that familiar class of drugs known as the beta blockers. If you're really fancy or want to impress somebody, you will call a beta blocker a beta adrenergic antagonist. But for us regular people, we just call them beta blockers. Now, beta blockers have multiple areas of effectiveness throughout the body. They can affect the cardiovascular system, which is what we're talking about here. And in that way, we want to primarily target the beta 1 receptors. But they also have effects on the renal system, on the respiratory system, primarily on beta 2 receptors. In the eyes, we use eye drops that are beta blockers for glaucoma. And even in the metabolic and endocrine systems, we see effects of beta blockers. Here's a list of beta blockers. Not all of them I have listed, and not all of these that you will use in your daily practice. But here is a list of some names that you may recognize. When you're selecting a beta blocker for a patient to treat hypertension, you must think about the selectivity of that agent for its receptors. So let's talk about the non-selective beta blockers first. These are agents that have no selectivity for either beta 1 or beta 2. They act both to block both beta 1 and beta 2 receptors. And these are agents like nadolol, propranolol, and timolol. Timolol is an ophthalmic beta blocker, by the way. Propranolol has the highest CNS penetration of all the beta blockers. So that means that it can be used for migraine prophylaxis and even for stage fright, but it does cause a lot of drowsiness. These non-selective agents do block beta 1, which is what we're targeting with hypertension, but they could have some untoward effects by blocking beta 2 receptors. Compare that to the selective beta blockers. So in this case, we're being more selective with the beta 1s. We're leaving the beta 2s alone. and therefore we're not affecting the beta 2s, which are primarily in the respiratory system. So these medications include things like atenolol, bisoprolol, metoprolol. Those names should sound familiar to you. And in fact, metoprolol and bisoprolol are both approved for use in heart failure. These, in most cases, would be preferable, especially in patients who also suffer with asthma or any kind of respiratory issue where they have to use a beta agonist like albuterol. Then there are some beta blockers that also have a mixed alpha blocking activity, and those are carvedilol and labetalol. Carvedilol is also approved for use in heart failure patients, and there could be specific cases where you might want some alpha blockade as well as a beta blockade. Two types of patients you really need to pay attention to when you're prescribing beta blockers are patients with either asthma or COPD and patients who are diabetic. Patients with asthma or COPD often use a medication that is a beta agonist for their disease. This could be a short-acting beta agonist like albuterol or a long-acting beta agonist like formoterol. This type of medication appears in lots of different asthma and COPD medications. A beta blocker, especially those that are not specific, could mitigate the effects of a beta agonist, as you might imagine. In diabetic patients, beta blockers could mask the symptoms of hypoglycemia. Usually we tell patients to look for things like sweating, tremor, lightheadedness. All of those are symptoms that blood sugar may be dropping and that they may need to take steps to increase their sugar through a quick sugar source. If the patient is on a beta blocker, some of these symptoms may be masked, or they may think it is a symptom of or an adverse reaction of the beta blocker. So it is very important that the patient is checking blood glucose even more regularly until they find out how the beta blocker affects them. Beta blockers are often used in pregnant patients, except for atenolol, which is category D, and therefore we avoid that one. Several beta blockers have black box warnings applied to them, and the wording may be different across different medications, but as a class, you can infer some general characteristics of warnings that I'll tell you about now. This is the boxed warning associated with atenolol, and this is the wording that comes directly from the package labeling, and it says that atenolol has been affiliated with poor outcomes when the drug is abruptly discontinued, especially in patients with coronary artery disease. So they're advising that atenolol in this case should never be stopped suddenly. It should be tapered off, and patients should be well aware that they should not stop taking their atenolol suddenly without supervision from a provider. Metoprolol has a similar warning. The wording is different, but this one says also that cessation of beta blockers without tapering has been affiliated with exacerbations of angina and even in some cases myocardial infarction. So metoprolol is yet another beta blocker that has a box warning on it saying don't discontinue abruptly. Not all beta blockers have this wording in their packaging, but as a whole, we should definitely warn patients not to disrupt their therapy with a beta blocker and not to discontinue it without talking to a provider. Sotalol is another beta blocker, and it has a different boxed warning that I want to call out for you. This one is not about discontinuing abruptly, but this one is one that is used in the hospital when a patient is admitted for an arrhythmia. Sotalol is more used for arrhythmias than it's not used for hypertension treatment. So in order to minimize the risk of an arrhythmia, that sotalol is initiated in a facility that can provide cardiac resuscitation, and EKG monitoring. So this is one that if you're in family practice, you may not see it very often, but if you do round in the hospital, you may see a patient that's admitted and started on Sotalol for atrial fibrillation, for instance. And that is one that has to be initiated in the hospital because they have to be on tele. Some of the more common complaints from patients who start beta blockers include the following. Bradycardia is very common, a slower heart rate, lower blood pressure, even hypotension, and that can cause patients to feel heavier limbs, feel tired, drowsiness, and lightheadedness. If they had a propensity toward CHF but maybe weren't an active heart failure, this may exacerbate them toward those symptoms. Certainly the patient in the first few weeks may feel fatigued, and CNS effects are more likely in those that are more likely to penetrate the CNS, like propranolol. But all of them can make the patient feel drowsy and dizzy. While not a mainstay of treatment, I do want to touch on peripheral vasodilators because they could be something you use in the short term, perhaps even for patients who don't have hypertension as a chronic disease, but may have a short-term issue with elevated blood pressure. I'm really talking about two medications here, hydralazine and minoxidil. Both of them act directly on the vasculature to relax and dilate arterial smooth muscle. For patients who are already on hypertension treatment, say with a beta blocker or a loop diuretic, these can be add-ons to get the patient down to goal. So these are generally not used for hypertension on their own. We typically use them as an auxiliary treatment on top of what they are already taking. They're both pregnancy category C. They can cause some rebound tachycardia. And hydralazine has been associated with a lupus-like syndrome. It's very rare, so I won't go into that too much. Minoxidil has also been associated with hair growth. In fact, you may recognize the name minoxidil because it is now used more so as a hair growth treatment called Rogaine. It started its days as a blood pressure medication. Now it's greatly eclipsed by other better medications, but minoxidil has a new life as Rogaine. Another peripheral tool in your hypertension tool shed are the alpha-2 agonists. These are not something that you would reach for directly, but it could be something that you could use if there are contraindications to the medications we've already discussed. Alpha-2 agonists work by direct action on the alpha-2 receptors. Now, alpha-2 is an inhibitory receptor. So by action on the alpha-2 receptor, we get vasodilation, we get decreased peripheral vascular resistance, and therefore decreased blood pressure and heart rate. It's mainly used for hypertension. There has been some new life in recent years off-label in use of ADHD. I'm not going to go into that right now, but just if you see it in that capacity, know that that is an off-label use. The alpha-2 agonists I'm thinking of here are clonidine, guanabins, guanfacine, and methyldopa. They come in mostly oral dosage forms. Clonidine actually does come in a transdermal patch. They're all on the Beers criteria, so it should be avoided in elderly patients. They can worsen depression. They have highly anticholinergic effects, so they can be highly sedating. They can also cause a lot of orthostatic hypotension. So generally, these are not the first, second, or even third medications you reach for in treating hypertension. But patient characteristics may dictate, because of contraindications, that you reach for some of these alpha-2 agonists. We also have alpha-1 antagonists used for a specific purpose for hypertension. The alpha-1 blockers in this case are doxazosin, prazosin, and terazosin. These are specifically or more efficiently used when a patient needs both treatment for hypertension and for BPH, benign prostatic hypertrophy. The reason these three drugs can be used in this capacity is because at the bladder neck and in the bladder, there are alpha-1 receptors. And by blocking these alpha-1 receptors, we can improve urine flow. We relax the smooth muscle at the bladder neck, improved urine flow in men who have BPH. And if the man also has hypertension, alpha-1 blockers are also throughout the cardiovascular system. We also get decreased vascular tone throughout the vasculature, and therefore we get lowered blood pressure. So this is they can certainly be used just for blood pressure, but this is kind of a case where you can get two disease states treated in one medication. There are alpha-1 blockers that are more prostate selective. So if you have a man who has BPH but not necessarily a blood pressure problem, you would select a alpha-1 blocker that is more prostate selective. We aren't going to cover that here. However, the non-selective agents do tend to have more adverse effects than the prostate-specific variety. The alpha-1 blockers that are non-specific do tend to cause a lot of drowsiness, lightheadedness, and dizziness. Because of the drowsiness and dizziness effect, they are on the Beers list, which means they are potentially inappropriate for elderly patients. And we should really look at patients who have liver dysfunction because they are metabolized through the hepatic system and may require a dose adjustment. Now let's take all the things that you've learned about medications used for hypertension and apply it to some actual patients. Our first patient is a 59-year-old Caucasian male patient with non-insulin dependent diabetes. He presents with concerns about his blood pressure. He was at the dentist recently, and the dentist told him his blood pressure was high. He was reclining in the dentist chair when the hygienist used a wrist blood pressure machine on him, but he doesn't remember what the numbers were. He says he thought it must be wrong since he has no symptoms, but just wanted a real doctor to check it. He takes metformin and glyburide for his diabetes, has no allergies. On physical exam, you find nothing unremarkable except for obesity. And performing an EKG, you also find it unremarkable. So some questions to think about with this patient. What could be the cause of his high blood pressure readings? Are there some non-pharmacologic things that you might suggest for this patient? At what point might we consider starting him on medication therapy to treat high blood pressure? And if he does need to start medications, what would be first-line therapy? Well, we don't know a lot about the situation other than he had one reading of blood pressure that was high. So white coat hypertension could be a valid reason why his blood pressure was high at the dentist. Perhaps he doesn't like dentists and he was getting a procedure that was making him nervous. It could also be pointed out that a wrist blood pressure machine is not entirely an accurate device to be measuring blood pressure clinically. We don't have subsequent readings on his blood pressure to see if this is a trend or a one-off measurement. So there could be a number of things that are causing his blood pressure to be high. If the patient is obese, as we have observed on physical exam, then it could be that he does have high blood pressure. We would just need to know more about his history and get a more accurate picture of his baseline. What are some non-pharmacologic things that the patient could do to lower blood pressure? Well, certainly he could be counseled on healthy lifestyle changes to lose weight, to lower his sodium intake. All of these things could benefit any patient, even if he is not chronically in the high blood pressure range. Certainly if we do have baseline readings that suggest he's trending toward hypertension, these would be the first things we need to do to make an intervention on his high blood pressure. If we look back in our records and we have some pretty good history of blood pressure readings for this patient. Perhaps he even has some home blood pressure readings that we could add into our own data. At what point do we make a decision that he should start medication therapy? Well, if the patient has a consistent average systolic blood pressure over 140 or a consistent diastolic blood pressure over 90, then med therapy is indicated. The guidelines say that 140 over 90 and below is the goal we should set for this patient because he is a diabetic and because he is under the age of 60. If we decide to start medication therapy for hypertension, what is first-line therapy? Well, virtually every patient would start on a diuretic for hypertension as first line. And it can often control blood pressure alone with diet and exercise. So given this patient's characteristics and that he's a diabetic, it's more than likely that he's going to require something more than a diuretic. The guidelines say that an ACE inhibitor or an ARB would also be beneficial for him since he is diabetic. Now let's move on to case number 2. We have a 62-year-old female who is African American. She is a non-smoker with pre-diabetes, and she presents to you for her annual physical. She doesn't have any complaints. Her average blood pressure in the last 2 readings in your office in her right arm is 143 over 88. She has no history of an MI, stroke, kidney disease, or heart failure. And after the visit, she says she measures her blood pressure at home and returns a month later. The average blood pressure from her home readings is 138 over 86. Her current meds are listed, as well as her allergies and her medical exam. You also have some cholesterol and lipid panel readings there. The questions I have for you for this patient are, number 1, what stage of hypertension do her readings indicate that she has? Number 2, what is this patient's ASCVD 10-year risk score? And based on that score, at what point should she start medication therapy? And number 3, if she needs to start medications, what's first-line therapy? You can calculate her ASCVD 10-year risk score by going to the link in your lecture notes or by Googling ASCVD 10-year risk. First question is, what stage of hypertension do this patient's reading indicate that she has? Based on the JNC8 staging information I gave you at the beginning of this discussion, it appears this patient has stage 1 hypertension. That's also according to the ACC and AHA guidelines from 2017. When you calculate this patient's ASCVD 10-year risk score, you get some recommendations along with her score. And it says that in patients with stage 1 hypertension with no other known atherosclerotic risk, the guidelines indicate treating with blood pressure lowering meds if her risk is 10% or greater. This patient's particular information indicate her risk is approximately 10.5%. So she's just above the threshold for starting medications. But in her case, I would start with a low dose first-line therapy medication. I think this patient would benefit from a thiazide diuretic, perhaps an ACE inhibitor, an ARB, or a calcium channel blocker. Remember, this patient is African American, and there are some specific recommendations for Black patients. And in this case, African Americans are recommended to get a thiazide and a calcium channel blocker, usually a thiazide first, and then add on a calcium channel blocker if necessary. They're more effective at lowering blood pressure and preventing cardiovascular risks in African American patients compared to ACEs and ARBs, for instance. Really, her cholesterol should also be addressed. I didn't ask you about that, but If you look at her lipid panel, she does have an issue there, and we probably need to talk about perhaps starting a lipid management medication as well. We'll talk about that at another time. Our third patient is a 67-year-old male patient. He has an average blood pressure of 151/92 over the span of several weeks. He started on a loop diuretic 4 weeks ago, but it hasn't quite effectively lowered his blood pressure. He's currently on Trelegy Ellipta for COPD. He has no allergies to food or medications. You notice on physical exam he has a slight shortness of air on exertion, and his labs indicate he has albumin in his urine. Questions I have for patient number 3 are, number 1, how do we advance his hypertension regimen? We've already started him and we're not quite there yet, so we need to advance his therapy. 2, what blood pressure medicines should we avoid in this patient and why? And 3, what does the presence of albumin in his urine indicate? In the case, I didn't give you any indication as to the race or ancestral background of the patient. But we do have some information about his age, and we know that he was started on a loop. So we need to advance his therapy, and in general we can say that if he was started on a diuretic and it hasn't quite lowered his blood pressure medication, there's 2 things that we can do simultaneously. 1, we need to address whether he is compliant with his medication regimen and with his lifestyle modifications. I would also add here that at 67, he may have some renal dysfunction. So a loop diuretic may not be the best choice for him on the scale of all the diuretics. We do have diuretics, of course, that can be used when creatinine clearance gets even below in the 20 milliliters per minute range. Metolazone in particular is what I'm thinking of. But we would need to assess what his renal function is like. When diet and exercise fails, along with a failure of diuretics alone to lower blood pressure, then we need to add a second medication. So in this patient, we could choose an ACE inhibitor, an ARB, or a calcium channel blocker. ACEs and ARBs are well tolerated, they're first-line agents. But however, ACEs can cause that dry cough related to the bradykinin issue, which might be problematic in this patient because he has COPD. The dry cough is a rare occurrence, and it may not really be an issue given the benefits that we know of in patients with hypertension for ACEs. But if it's something that we want to avoid, definitely we could just start with an ARB in this patient. We should definitely avoid beta blockers, however, because he uses a medication for his COPD that includes a beta agonist. His inhaler has a beta agonist in it, and if we give him a beta blocker, it's going to make that beta agonist work less effectively, essentially stymieing his COPD treatment. Now, this is probably something you had to look up. What does the presence of albumin in the urine indicate? And why am I asking this in the first place? Well, albumin in the urine is indicative of some level of kidney disease. ACEs and ARBs have been shown to slow the progression of kidney dysfunction, but they shouldn't be used together, of course. So in this patient, that might indicate that an ACE and an ARB actually may be a good choice, even with the risk of dry cough in his COPD, because of the indication that he might have some level of kidney dysfunction. I hope those cases help you pull together all of the medications that we discussed in managing hypertension with medications. Thank you for joining me. This is Dr. Amber Can.